Good morning, everyone. This is Dr. Morgan Edmondson here with Evoke Neuroscience. I am the Director of Medical Affairs for Evoke. I'm pleased to be hosting your Lunch and Learn webinar this morning or this afternoon, depending on where you are in the country. And here with us today, we've got Dr. Mitch Finney. He's going to be sharing some case studies with us today. Dr. Finney, are you there with me?
Yeah, I'm here.
Perfect.
I may even
All
have the
right, so we've
camera
got audio for both of us. And I want to make sure that everyone in the audience hear us as well. So if you've called into the webinar, I want you to go to your GoToWebinar toolbar and find the questions section. Type in there, let me know that you can hear me and that you can see my screen. And I want to know if you personally are feeling ready for fall or if you're going to miss summer. I am in Northern California right now, and it's supposed to be 100 degrees today. So even though it's technically fall, it still feels like summer. So we're getting a bit of both. And it looks like everyone can hear me and that people are ready for fall. They're ready for it. I think we're all ready for the end of 2020. Maybe that's it. All right. So today we're going to be talking about understanding blue brain, which really is global low power. I'll explain what that term means, but blue brain, as you might suggest, think of, is just blue all over the brain for basically all of the frequency bands we're interested in. So we're going to dissect why that can be seen, what different types of disease states cause it, and then get into different treatment and therapeutic approaches for it. And that's where Dr. Finney will come in and share some of his case studies. So learning objectives for today. First off, we need to recognize global low power in our QEEG head maps. I want you to be able to describe the different biomarkers that are often seen in conjunction with blue brain. So there are two different biomarkers that we see that usually correlate when blue brain pops up, and recognize different symptoms that can go along when you see those biomarkers. I want you to understand the different pathophysiological causes for this global low power. That'll be a really large component of today's talk, understanding why we see blue brain. I want you to be able to name different patient symptoms that are related to low power. And then importantly, I want you to describe the relationship between vascular function and cognitive function. You'll see a lot of different therapeutic treatments really play on the vascular system in order to target the cognitive system, cognitive functioning. So those two are highly interrelated, and we'll be touching on that today. So diving right in, I want to talk about the QEEG signature that's representative of blue brain. And before we dive all the way in, I want to let you know if you're wanting to make notes on this presentation, you can access the PDF of the presentation file in your handout section of the GoToWebinar. And if we're saying something that doesn't make total sense to you, just type in that question box and we'll get to your questions hopefully when we can. So this QEEG signature is pretty easy peasy to recognize. You're looking for a blue brain. That's why we colloquially call it blue brain. And it's just reflected in your resting state head maps. You're going to see it in eyes open as well as eyes closed. Often it is more prevalent in eyes closed, but you'll see this pattern in both conditions. And it's pretty much blue throughout the brain and throughout all of our frequency bands. So to just orient you quickly to what we're talking about when we say QEEG or our resting state EEG, of course, EEG is measuring electrical activity of the brain in real time. So we know that neurons communicate via action potentials, which are created by the exchange between sodium and potassium into and out of the cell. And when this wave of ions reaches electrodes that you put on the scalp, they're going to push or pull electrons on the little metal surfaces of the electrodes. And this push or pull difference is measured as voltage across time. And we can look at different wave speeds of these brain waves. So on the y-axis here, we're looking at amplitude, meaning the voltage that's present within each frequency. And on the x-axis, we're looking at frequency. So the speed of brain waves is under consideration, and it's just measured in hertz, the number of cycles per second of the brain's electrical activity. Now, the reason why it's important to think about the x-axis in frequency bands is because all frequencies are generated in the brain all of the time, but the amount of each frequency changes depending on what the patient is doing or physiological state and pathology. And these bands relate to different types of behaviors. So delta is our slowest brainwave band. It relates to slow cognitive processes. You're going to produce more delta when you are sleeping. A little bit faster is theta. Theta waves are related to a sensation of feeling drowsy. So when you're right about to fall asleep, you're producing a lot of theta. Or if you're checked out mentally and off in la la land, that's also producing a lot of theta. Alpha tends to be our state of normalcy. We're producing mostly alpha most of the time, so can be considered our resting frequency band. And then beta is our active frequency band. So when you are mentally engaged, you're problem solving, you're thinking critically, you're going to have a boost in beta. So the way that we map QEEG head maps is on a head itself. Instead of looking at that frequency spectrum breakdown, we're going to look at pictures of heads. And we're going to ask, how is your patient's brain function compared to a healthy control database? So this picture on the right is an aerial view of heads, and each head represents one frequency. So we've got 2 hertz all the way through 30 hertz, and it's a top-down view. So the nose is in the front, left ear on the left, right ear on the right. So it's opposite of radiological convention. And we're going to map activity based off of z-scores. So how many standard deviations away from normal your patient's brain is. So green means 0 deviations away from normal. They're right on the money compared to that standardized database. But if you see blue, that means they're not producing enough of that particular frequency in that particular brain region, whereas red means they're producing too much of that frequency in that region. So when we interpret our head maps, first we want to consider which frequency we're looking at. Is it a slow wave? Is it a fast wave? And the reason why is because, again, those frequency bands tend to relate to disease pathology. So for example, you're going to see mood disorders show up a lot in the alpha frequency band. You also want to ask yourself, what power are you seeing? Is it blue or is it red? Do you have low power or high power? Again, this is a comparison to a normalized database, and ideally we're looking for green everywhere. Today, we're going to be asking what causes blue to be everywhere. And finally, we care about what brain region you're seeing this dysfunction in. Oftentimes, seeing where this dysfunction occurs will help explain symptoms. So for example, if there's dysfunction in the frontal lobe, you're going to see symptoms related to emotional and behavioral control. Today, with global low power, you'll see that there's dysfunction throughout all regions of the brain, and that has a different type of symptomatology altogether. So diving into blue brain. No surprise here, blue brain means there's global low power in all of our frequency bands. So what global low power means is basically seen in all brain regions. So global, think of the head as a globe. Global low power, you're seeing it in the frontal lobe, the temporal lobe, parietal lobe, occipital lobe. All of the above is going to have blue. And notably, blue brain tends to be displayed in all of our frequency bands. So here you can see there's a little bit of blue starting at 2 hertz, getting pretty intense at 4 hertz, and then staying with us all the way through 30 hertz. So it's global low power that's seen throughout our frequency spectrum. And essentially what this means is the brain is sluggish and lacking energy. So remember, this is a comparison of your patient's brain to our standardized database. Blue means they're not producing enough of that frequency. So here, they're not producing enough of any of the frequencies. So it's like almost like the brain is dampened. Its functioning is quiet, and it's just sluggish and doesn't have the energy that it needs to produce these frequencies in the increased amount that would be considered normal. So there's a lot of different associated disorders. We're going to be hitting a couple of them today, the most common, I would say. The first can be thought of as basically mitochondrial dysfunction or low ATP, which makes sense, right? If you have mitochondrial dysfunction or low ATP, the brain literally isn't producing enough energy to support these types of cognitive processes throughout our frequency spectrum. Hormone imbalances are often a culprit as well, especially when it comes to the thyroid. And then low gray matter volume can be a culprit here too. If you think of neural atrophy, whether it's specific to the hippocampus or kind of globally, if you don't have the neural resources physically to create this type of electrical activity, it's going to result in blue brain. And associated symptoms tend to be related to chronic fatigue type of presentation. So mood and affect changes can be seen here, especially depression, chronic fatigue, as well as cognitive impairment and dementia type symptoms. If you think of just a total lack of brain energy to go into any type of neural computation that we need to be performing on a day-to-day basis, on a moment-to-moment basis, it's no wonder that cognitive impairment is going to be seen in subjects that have this type of neurological pattern. So that's our clear-cut blue brain, right? It's easy to recognize. You see a sea of blue, you're thinking blue brain. But there are a couple other biomarkers that tend to go hand in hand with blue brain. Low HRV is one of them. So HRV reflects vascular compliance and autonomic nervous system function. It's basically the heart-brain interconnection. And low SDNN, which is the standard deviation of end-to-end intervals, or low total power, which basically reflects vagal tone. These are correlated with sleep abnormalities, mood alterations, increased incidence of depression, and higher risk of cardiac events. And we'll often see low HRV go hand in hand with blue brain. The reason why is the vascular system is very tightly tied to blue brain. Sometimes targeting the vascular system itself will help resolve blue brain, and that's what Dr. Finney is going to be sharing with us later today with his case studies. So it's pretty common to see low HRV show up in a patient that has blue brain. Another thing that you'll see is low amplitude in your ERPs. So ERPs, event-related potentials. This is a biomarker that reflects brain processing speed and efficiency. Sometimes you'll see an indiscernible result, which basically means no peak can be detected. Normally, in a P3B waveform, as shown here on the right, you're going to see a large mountain peak, and that would be ideal. Here, there is no peak detected. It's an indiscernible result, meaning clinically that this is a pretty severe case, and we would see this low amplitude correlated with essentially a lack of neural horsepower. So things like poor attention, information processing, and general cognitive function are going to be symptomatically related to low amplitude ERP. And it makes sense of why blue brain would be linked to low amplitude ERPs. Again, there's just literally a lack of energy to do any type of processing. And not only in resting state condition, but behaviorally in our go, no-go task where we're measuring the ERPs. Okay, so if you see blue brain, you now know, okay, it's not a plethora of other things that I was perhaps considering. So, but you just listed 3 different options that it could be, right? Is it mitochondrial dysfunction? Is it a hormone imbalance? So what am I supposed to do next? So blue brain is one that when you see it, you've ruled some things out, but there's still a little bit more investigational work to be done. So the first thing you're going to want to evaluate and maybe rule out is mitochondrial dysfunction. So we know that mitochondria are the key organelle responsible for cellular energy production. At the molecular level, we're looking at a reduction in mitochondrial function that leads to a reduction in ATP. And we know that ATP is our cellular power. So if you don't have ATP, you're not powering up any of the cellular processes that you need to. So it's no surprise that mitochondrial dysfunction can affect systematically, basically every organ system in the body, including the brain. So the first line tests that I would suggest running include blood testing. Really, the complete metabolic panel is going to get you most of the way of where you need to go, but testing another of different profiles as well, in addition to urine testing. And there's a lot of different syndromes related to mitochondrial dysfunction. But in this table, it's basically showing you in a relatively small study, but nevertheless, a lot of different syndromes are going to show up in an abnormal EEG. So notably, blue brain here, it's not going to be specific to any one type of syndrome related to mitochondrial dysfunction, but it is sensitive to it, and it's reflecting just a lack of cellular energy, a lack of ATP related to this mitochondrial dysfunction. So when you see blue brain, I want you to think, could this be a mitochondrial dysfunction disorder? Next up, I want you to think about, is this related to a hormone imbalance? Specifically, the thyroid comes into play here. So we know that the function of the thyroid gland is to take iodine and convert it into T3 and T4, and it plays a big role in metabolism, growth, and development, and really helps regulate a lot of our bodily functions. Hypothyroidism in particular is correlated with global low voltage in theta and alpha 1. So this is an example from a case study of a woman around age 55, and this is blue brain, right? It's not aggressively blue like the sea of blue we saw in our previous example, but this low power in theta and alpha 1 was related to a thyroid problem, and she was later diagnosed with hypothyroidism. So keep an eye out for that. And the symptomatic manifestations of this can be memory changes and depression. So it's keeping in line with the symptoms we see related to blue brain, but here we know that it's ultimately due to a thyroid problem. And the reason why we see these types of symptoms is because the decreased cerebral blood flow that usually accompanies thyroid disorders. So I put that in bold because later on when we get to discussing intervention ideas and case studies, it's really playing on blood flow. It's playing on the vascular system in order to target and treat the brain. And it makes sense here of even correcting any type of thyroid abnormality. It's going to influence cerebral blood flow and hopefully reverse this blue brain type of EEG pattern. And interestingly, when you optimize T3 and T4 and TSH in clinical and subclinical thyroid dysfunction, that improves vascular compliance through improved endothelial function. So it's all about the vascular system and how it's influencing brain function. If we can get our vascular compliance in order, then the blue brain is going to resolve and symptoms will hopefully be resolved along with it. And finally, I want to talk about low gray matter volume. So when you think about gray matter atrophy, that means reduced neural resources, which creates blue brain, right? If you literally don't have the neural resources to power any type of electrical communication within the cortex, you're going to see blue brain, because again, blue brain means you're just not creating the same type of energy that you would see normally. And hippocampal atrophy in particular has been shown to be related to reduced alpha power. So this is pulled from a study, Baglioni, back in 2009. and essentially looking at the parietal, occipital, and temporal regions of the brain, so quite global. And you can see the differences between an Alzheimer's group, MCI group, and a control group. Here, the green diamond is our Alzheimer's group, and low gray matter volume, especially in the hippocampus for this Alzheimer's group. And it's going to be related to a lower power in especially in this alpha range. So we can keep an eye out for that. And it's easily confirmed via MRI. So if you see blue brain and you think it might be related to low gray matter volume, do an MRI. You're going to see very clearly that there's neural atrophy, maybe concentrated in specific areas like the hippocampus, and maybe globally throughout the cortex. And notably, this type of blue brain is correlated with neurodegenerative dementias like middle or late stage Alzheimer's and dementia with Lewy bodies. And I do want to note, it's really not the early stages of dementias where you're going to see blue brain like this. At this point, neural atrophy has already occurred, it's getting worse, and it's enough to affect the way the brain is functioning on an electrical level. So this is not one of our early indicators of cognitive impairment related to dementias. It's a much later indicator. So you will definitely symptomatology that is very clear memory and cognition problems. And so it's no surprise you're going to usually see this type of blue brain signature with our other classic dementia biomarkers. So slow peak alpha frequency, and then our poor P3A and P3B. So interventions, assuming that you have figured out if there was some type of mitochondrial dysfunction or hormone imbalance, of course, it's up to you to treat that accordingly. But there are some interventions that can treat kind of a global low power that isn't tied to any type of specific imbalance that showed up in blood and urine testing. And that's really because vascular function, as we've said earlier, can impact very greatly cognitive function. So when you think about kind of overall health and what's good for the heart is what's good for the brain, we're targeting things like physical inactivity, managing diabetes, and treating hypertension. And this, I love this graph because it's showing how what's going on in the periphery, specifically with blood pressure, is affecting the brain itself. So arterial blood pressure can impact and does impact cerebral blood flow. Of course, that makes sense. That's logical. But then cerebral blood flow has this graph that goes outward, right? We're now talking about cerebrovascular disease. We're talking about proper clearance of beta amyloid. So if you don't have that blood flow, then we can't get our cleanup cells into the brain to do their work and to get rid of all the junk in the brain. So super important to have healthy arterial blood pressure to affect the way the brain's functioning, to maintain proper brain function. So something that we know works for controlling blood pressure and really managing hypotension well is nitric oxide. So this, of course, won the Nobel Prize in Physiology or Medicine in 1998. And we know that NO signals smooth muscle cells and induces increased compliance, enhancing blood flow throughout the vascular tree. Now, I say vascular tree because I'm not just the heart here, I'm not just talking about the body, but influences vascular blood flow all the way up through the brain as well. And so notably, nitric oxide tends to decline due to a couple different things. The first is a natural decline with age. It's just a fact. It is what it is. Men that are 40 are producing half of the nitric oxide they did at age 20, and women age 50 are producing 35% of what they did at age 20. So this is something that just naturally drops off with age. It can also be impacted by a lack of dietary nitrates found in leafy greens. Nitrates are metabolized into nitric oxide in the body by oral nitrate reducing bacteria. So if we're not consuming enough of our high nitrate veggies, like the leafy greens, then we're going to become nitric oxide deficient and our levels of nitric oxide are going to fall. And then lack of exercise is a big one here as well. Physical exercise is actually the most potent stimulator of nitric oxide production. And of course, it's one of the top strategies for supporting overall cardiovascular health. When we don't exercise, we lose the important signal that tells our body to make more nitric oxide. And as a result, the enzyme making nitric oxide in response to exercise becomes dysfunctional. So not a good thing. We need to keep exercising. Of course, that can be difficult in terms of patient compliance, as well as dietary manipulations. Exercise and diet, I think, are the thing that as physicians we maybe hound the most, but it's hard to get patients on board with that. So an intervention is a nitric oxide supplement. And, of course, this was originally intended to affect systolic and diastolic blood pressure. And it does this really well. Giving a supplement significantly decreases both resting systolic and diastolic blood pressure, 12 and 6 points dropped respectively. It improves vascular compliance and it also improves endothelial function. So it's doing its job very well in terms of managing blood pressure and boosting vascular compliance. But the question now is, can nitric oxide help blue brain? And if we think about it like this, so if cognitive function is positively affected by improved vascular compliance, we already know that. There's been great studies in the Alzheimer's space looking to see, well, if we manage blood pressure and get it under a certain level, will that enhance cognitive function? And it does. So we know that relationship is solid. We also know that vascular compliance is improved by nitric oxide supplementation. That's a solid relationship. So now the question is, does nitric oxide supplementation boost global low power? And will it resolve cognitive symptoms? So to help us kind of dissect that relationship and give some practical case studies that he's done in his own practice, we have with us today Dr. Mitch Finney. Dr. Finney practices in San Antonio, Texas. He's board certified in family medicine and went to Baylor. And he's been an EVOX user for, I think, a year or two now, and has wonderful case studies of looking to see how can we correct blue brain. A question came in from one of our audience members today saying that they've only seen one blue brain case. And so maybe it's just the luck of the draw, but Dr. Finney has seen a number of them, and he has taken some really innovative approaches to try and correct this type of brain pattern. So Dr. Finney, I will hand it off to you. Thank you so much for joining us and discussing these case studies. I'm really excited to learn what you've done in your own practice to treat these type of patients.
Thank you, Morgan. Maybe it's just South Texas. We're kind of slow down here, and so we get more blue brain. But no, it's interesting. As you mentioned, my background is a lot of atherosclerosis and kind of heart attack prevention, ischemic stroke prevention, and it's interesting how all this ties in very well. Actually, I got into EVOX simply because my patients were living a long time, and they all start worrying about getting Alzheimer's, and so I needed a test to help me figure out if they're going to get Alzheimer's because mom had it and stuff. But anyway, when we ran across this blue brain, and I've been playing with a supplement called Neo 40, which is a nitric oxide supplement, and have had some interesting results. And these are just three of them. The first one is a 75-year-old white male, very nice gentleman, past medical history, really is only significant for prostate cancer, treated with radiation. He's very active in the church, and he leads a pilgrimage ministry that he's been to the Holy Land about 50 times over the last 25 years. About 4 years ago, started complaining that his memory and cognition was a problem. He was worried about Alzheimer's because his older sister had severe Alzheimer's. And so we did a workup at that time in 2016, including the MRIs and some laboratory stuff. And basically that was negative. It didn't give us a lot of guidance and just saying, I think you're okay, but he still didn't feel great. So we ordered it. Finally, once I started doing the EVOX in 2019, we got one of those in December, which I believe is on the next slide, his initial EVOX study. You can advance one there, Morgan. There we go. And he does have blue brain, as you can see. And that one's kind of classic and it's quite blue. A couple of things I just look at on here. One is from his worry of dementia, looking at the peak alpha frequency in his 300A and 300B, and his peak alpha and 300A were good, so that was very reassuring, and he didn't have kind of a classic Alzheimer's process, at least from my understanding and limited knowledge of EVOX. Anyway, we went ahead and started him on the Neo 40, and I tend to underdose. I think officially you're supposed to start with 2 a day for about a month or two and then go down to 1, but we just gave him 1 a day and to see. And so I think the next EVOX was about 6 months later. This first one I think was December, and we followed up I think in July of this year. And we'll see that. And it's going to be very, very subtle. You don't see a whole lot. It still looks pretty blue. If you look at the very low frequencies and the delta, we see a lot more green. And if you look in the high frequencies and that beta 2, the 26 to 30 hertz, that you're starting to see some green when there was all blue before. Still, peak alpha is good, and his amplitude, the 300B amplitude is good. What's also of interest is that 300B was indiscernible, and now at least he's got something there. So it seems like we may be having a little more activity there as well. Interestingly, I asked him, I literally saw him this past week, and I said, do you feel much different? He says, I don't think I feel a whole lot different. But if you look back, and I think we may have the two side by side, or maybe not, but no, I guess we don't if we can go back. But his self-reported complaints actually were different. And if we go back and look at his self-reported scale, that it was a marked difference. Well, I shouldn't say marked. It was at least noticeably different between the first and the second. So one, the subtle changes we saw on the blue brain, and then things such as executive function and attention got significantly better, as well as his sensory and motor complaints on the questionnaire that the patients fill out beforehand. So again, not real dramatic. We'll have a couple others that may show a few better changes or a little more dramatic on the brain maps. But he was one of my first Neo 40 patients that I did. We go into case number 2.
That's great. Before we move on, I just wanted to note that I do, the head maps are very subtle changes, and maybe not something that we can place an overly excited interpretation of. But something I am excited to see is this difference in P3B from baseline to follow-up. We went from indiscernible to at least registering a peak, which is great. So again, just to reiterate for our audience, indiscernible doesn't mean that there's lacking data. It means that this patient is so bad off that we can't even detect a peak that's supposed to be there. So in the follow-up, no, we're not in the good range, but at least we're creating a peak. So that is a big step in the right direction.
Exactly. Okay. So we'll continue, and we'll find out in another 6 months how things are going. We'll go on to case number 2. This one's a 57-year-old white female. Her story is interesting. She's been diagnosed with multiple sclerosis, based primarily on UTOS phenomenon. I'm a big fan of that just because I personally have the same problem, and it took about 10 years for someone to figure out what was going on. But what that is basically when her body heats up, she doesn't see well out of her right eye. She also had things like what she calls a floppy foot and some fatigue and stuff. We did a MRI related to the UTOS phenomenon back in 2019 that did show some demyelinating lesions, which the neuro-ophthalmologist felt was very consistent with her MS. situation, and the MRI with contrast was done looking for active demyelation, which was negative. Interestingly, she was not initially, but later started on Copaxone, which is one of the very expensive medicines that are used for MS. That, it's one of those things that we're confused if it makes a difference, because some MS patients don't get worse and some get real bad quickly. But anyway, she's been on that since June, and we'll look at her EVOX. I believe her first EVOX was back in 2019. We'll see that one. And just a note on ordering EVOX too. Her diagnosis was fatigue. What we found is diagnoses like insomnia, depression, anxiety, mild cognitive impairment, fatigue are things that are billable or reimbursable easier with insurance and Medicare carriers and stuff. So officially this was for fatigue. And if you look at her brain maps, she's not real marked, but she's got blue brain throughout, and so she definitely has a blue head. And again, as expected, her peak alpha is very good, and her 300A and 300B amplitudes are very good, because cognition was not her concern. If anything, it was just mainly fatigue. And so we do see the blue brain kind of throughout there. And she was started on the Neo 40 also, just one a day from the beginning. And then we had a repeat, I think, roughly 6 months later from this baseline study. And here's the follow-up, and you can't tell right away, but there's more green in this study than in the initial one. The other parameters stayed the same with the peak alpha and 300A and 300B. Clinically, again, she didn't say a whole lot. She did say her walking was better, and she was having less falls for sure. The fatigue, she said, she still had, but was sleeping well. And then the vision, there weren't really any changes in her Uthoff's phenomenon that kind of started this whole process. The same story as with the first case was that her self-reported symptoms also improved. Again, if you just ask her off the bat, she goes, I don't know if I noticed a lot of difference, but if you go specifically at what she's answered on the questionnaire, that she did get better. And in her case, we actually ended up having the third EVOX done just recently in July of this year in 2020, which again was about a year from her very initial study. And we'll take a look at that one. And this one's got even more green. Again, you still have the blue background there, but in a moment we'll compare this last one to the one the year prior, which is a year on Neo 40, and it's a clear difference in that. And we'll go ahead and show those two side by side here. And so again, going from mostly blue to probably mostly green at this point, and then at the bottom her self-reported symptoms. Again, not dramatic, but it is, I think, fairly significant. That's the nice thing I like about the self-reported questions that we ask patients, because they don't usually report globally what's going on, but sometimes we can look at that and see a difference as well. So, and she's tolerating the Neo 40 and just continues at one a day. And we'll see if anything else continues to improve. Yeah, we'll go ahead and go on to the third case study. There we go. 67-year-old white male. He did have mainly cognitive or memory issues or concerns since September, or roughly a year ago, 2019. Married Navy veteran, self-employed. Past medical history really only significant for back pain. And what happened, he had a very classic radiculopathy, had that repaired, but unfortunately that failed, and then he ended up getting a spinal cord stimulator, which then became infected, and had that removed, and so I had a lot of kind of chronic pain issues with that. And during that time also developed an overactive bladder, which will come into play a little bit with what we see, I think, on his follow-up EVOX study. Again, past medical history and surgical, mainly related to the back and the prostate. He does have a history of Alzheimer's, and so was concerned from an Alzheimer's perspective if that was going on with him in his 60s here. We'll look at his first study that was performed. Let's see. And again, he's kind of between the two that we saw before. He does have pretty much at every frequency blue brain, more prominent in some than in other places. From the Alzheimer's perspective, again, the peak alpha is pretty good at 8.9, not great, but it's okay, and its 300A is okay also. So at least voting against Alzheimer's at those levels. And then he also was started on the Neo 40 just at 1 daily at this time. I think this was about 6 months later when we got his follow-up. 9 months later, okay. And this one's pretty dramatic. You can see a big difference. The blue has turned pretty green, and even in some areas we see high power up in the higher frequencies. Interesting, if you look at his peak alpha, he went from green to yellow, but actually the number is the same. It's 8.9 in both of them. 300A stayed about the same, as well as 300B. With the reason I mentioned the bladder issues was he was started on basically a barbiturate type medication by urology, and I think that explains his high power and the higher frequencies there. But again, just back to the blue brain stuff, you can see pretty dramatically over the 9 months of taking just one Neo 40 a day, that has changed dramatically, and symptom-wise too, he reports much improvement. You can see on his self-reported scores on the two tests. So anyway, I think enough. So it's a new thing. The Neo 40, just from clinical experience, I've probably had maybe 10 patients take it so far to some degree. Generally tolerated very well. The way it comes is a kind of a dissolvable tablet that you dissolve and take before you eat breakfast typically, and it's well tolerated. There was one potential gastric complaint, but then there was other complicating factors that I think was probably causing the gastritis symptoms and stuff. But it's been very well tolerated. And I use Neo 40 as one name brand I literally get from Amazon. I think the company is called Human. And the one catch for me, I'm kind of simple and I try to do things very inexpensively. So this is about the most expensive supplement that I use. It's about $1.40 a day, I think. Whereas I try to stay under $1 a day for any vitamins and things like that. But it definitely has made a difference, and I think at least in these three has shown a difference both subjectively with their self-reported symptoms and even objectively, which is nice about the brain maps on the EVOX that you can show the patient the difference, and that's very encouraging. So that's all that I have, Morgan.
Absolutely. Well, thanks so much for sharing these case studies. And you're right, I love to see the repeat testing and the differences, as in this case, a huge difference in 9 months, that a supplement like Neo 40 can make. We did have a question come in about if these cases are they still taking the daily Neo 40, and is that your plan to kind of keep them on this for long term?
Yeah, at least for now. And again, obviously it's brand new, so I'm not sure if long term is 10 years or 5 years or what we're going to do. But all three of these are still taking the Neo 40, and I think we'll continue. I'm assuming probably maybe a few years down the road we may take a little supplement holiday and see what happens. Mm-hmm. And that's also one of the nice things about Evox. It kind of gives me a picture to look at. And so if, for example, case number 3, if he quits for a year and he goes back looking like his baseline study, then he'd probably take it forever, I think. And so,
okay.
But yeah, they're all still taking it right now.
Okay, that makes sense. We had another question as well on if any of these patients had made any dietary or exercise changes. As we learned earlier in the talk, diet and exercise are known to impact nitric oxide. We know what's good for the heart is good for the brain. So are you fairly confident in attributing the changes we see here to the Neo 40 supplement, or could it be something else?
No, and definitely I always encourage the exercise too. A couple things, for example, on number 3, he did not change related to his back. He's fairly limited physically and stuff, so definitely he has not done anything. The second case, the lady with the floppy foot and the MS, interestingly, because she was walking better, she actually did do more exercise because she wasn't falling as often. So in that sense, was probably being more physically active, but I wouldn't necessarily dramatically different. And then the first one, not a whole lot different. He always was fairly physically active, and I don't think his activity changed to any significant degree. Of course, we saw very subtle changes on his brain maps, but for sure the third one, his activity has not changed at all.
Mm-hmm. Okay, cool. And one final question is, those at risk for cognitive problems are of an age at risk for orthostatic hypotension and falls. Nitric oxide is a potent vasodilator, so any recommendations on how to approach patients with this in mind?
That's a good point. Yeah, and I have not seen that. Obviously, it's a very, very limited sampling that I have of about 10 patients. Um, the one, just practically speaking, the vast majority of these patients are already taking antihypertensives because they have hypertension. And if that is noticed at all, it's usually pretty simple to start taking away other medications that are lowering their blood pressure as well. But I have not seen that. The two males with the phosphodiesterase inhibitors for erectile dysfunction also can be a potential problem. I have not seen that yet, but I would probably exercise some extra caution if I had a regular Cialis user and then was going to try to use some Neo 40. And usually too, those folks, I have not run into that yet, but I would probably consider dosing in the evenings at bedtime and to try to minimize the orthostatic and the falls literally in the day and stuff like that. So
Mm-hmm.
again, not seen, but yeah, definitely I think is a very real possibility.
Yeah, absolutely. Great. Well, thank you so much again, Dr. Finney, for sharing these cases. As you said, it's kind of a new approach that you've used in your practice, but in terms of kind of our final thoughts for the day, what do we do when there's blue brain? We want to diagnose the cause. Could it be um, an ATP, a lack of ATP? Could it be hormone abnormalities? And if it's not anything that we can tie to, if we have normal labs that come back, how can we really approach solving this? So NO could be a supplement that we use to boost global power. We've seen it in Dr. Finney's practice be pretty effective at that, especially in case number 3. It's such a stark contrast, and all we're doing is boosting nitric oxide levels. So just something to consider when you come across this in your practice. Now, hopefully you understand the cause of it. We understand symptoms that can go hand in hand, and now maybe you have an idea of a therapeutic approach. So that is it for our webinar today. Thank you so much for joining for our audience, and thank you especially to Dr. Finney for taking the time this morning and sharing these case studies with us. Folks, if you have any follow-up questions about today's Lunch and Learn, if you're working through a challenging patient case, or if you want more clinical education materials like this, shoot me an email at medicalaffairs@evokeneuroscience.com. I'll be able to help you out. Thank you again for joining us, and thank you very much to Dr. Finney.
You're welcome. Bye-bye.